Welcome, everyone. We're so happy to have you with us today. We have an all-star lineup for you, and I'm very, very excited to introduce our big webinar on avoiding bias in research trials, the ethics of socioeconomic opportunities. Today, we have three people who have a wealth of experience, and I'm excited to introduce them all. We have Dr. Keith Melancon, Dr. Wendy Ellis, and Dr. Nia Bodrick with us today. You'll hear from each of them in turn, and then we'll have a discussion following with your questions. Thank you for submitting them in advance, and we'll go through questions that you might have today. And we're very lucky to have you all. Thank you. Thank you for joining us today. So, Dr. Melancon, if you don't mind starting us out with as I know very well, you are a fabulous storyteller, and I thought you might give us a few examples of ideas and research trials, things that you've seen specifically that we can ground ourselves in thinking about the topic today.
Thank you, Melissa. So, it's funny because my my career in transplantation started with a research trial. And I can tell you that ever since then, I have seen on both ends why minority representation in trials is of the utmost importance. I just want to give you guys a couple of vignettes, but I think it well encompasses what we want to discuss today. When I was a student, I was a medical student at Tulane University in New Orleans, Louisiana. Uh, Mardi Gras was yesterday, so happy Mardi Gras to everyone. Today's Ash Wednesday. But I did a study as a student where the transplant surgeon, I'm a transplant surgeon now, I run the program here at GW, but the transplant surgeon at Tulane at the time, knowing I was a student who wanted to do research, gave me a project. It was a very simple project. He said, "Hey, Keith, I want you to look at the outcomes of kidney transplantation here at Tulane. And I want you to look at the Black patients versus the white patients. I just want you to look at outcomes." So, I mean, it was a very simple study. We separated out the patients by race, and there was a huge difference in outcomes. And I did a lot more of follow-up after that original study. And what I found was, there's a big difference in how African American patients metabolize certain medications compared to white patients. And what the reason why it was surprising, or it was surprising to a lot of people in organ transplantation, was that this was not originally known, primarily because when these very important medications, which continue to be the cornerstone of immunosuppression, were tested in the trials, there were very few African American patients in the trials. So it was a surprise to everyone. And what does that mean? Well, what it meant was that the African American patients were not given the proper dosage. And therefore, they had a lot more rejection earlier. And then when they finally figured out that there was a difference, they had to give much higher dosages, and they had much more toxicity and possible non-compliance. So the fact that they didn't include African American patients in the original trial really impacted how these drugs were utilized and outcomes after transplantation. I figured this out. I mean, not myself, but I saw this as a student, and it's something that I've followed for the rest of my career. Now, let me give you the opposite. So later in my career, after I became a transplant surgeon, there was a trial done here at the NIH where this new genetic variant was being studied as to why African Americans have so much kidney disease. If you don't know this, we make up about 13% of the population, African Americans, but we make up almost 36% of the people that have end stage renal disease. So we have a lot more kidney disease in Black patients than you have in white patients. So the question's always been why? Well, if you know the reasons for kidney disease, and the top three are high blood pressure, diabetes, and obesity, you would understand that, we have a lot of these problems in all Americans, but particularly in the African American community. But anyway, this genetic variant was figured out in the late 90s, early 2000s, and there was a lot of emphasis on this. It's called ApoL1, and it's a gene that is carried mostly by African Americans in this country and people from Africa. And it has to do with an advantage for killing a parasite, the uh, the parasite that causes sleeping sickness, right? Which is deadly. We don't see it here in the United States, but obviously they see it in Africa. So if you carry that gene, particularly if you carry both copies of the gene, then you are protected against dying from sleeping sickness. However, there is a correlation with kidney disease. So all of these research studies, people's theses, PhD theses, were based on looking at ApoL1 and how to avoid kidney disease in African Americans because of this gene, which I think is laudable work. However, I remember, being a person who treats kidney disease every day, I kept making the point that there's a lot of very correctable reasons why Black people have kidney disease: high blood pressure, diabetes, obesity. If we took half the effort and money and put it into making sure people didn't have high blood pressure, diabetes, and obesity, we would do a lot more toward kidney disease than focusing on these genetic variants, which is a really just associated with kidney disease. In other words, if you have both copies of the gene, you still may not have any kidney disease. It's associated with kidney disease. There's a huge study that's being done currently and has been going on for the last almost 5 years, and good data will come from that. But the fact that the study is going on and has not published any substantial sort of impactful data tells you that it's not really obvious that these genes cause a lot of the problems in African American patients. However, I will tell you, we know without any doubt high blood pressure, diabetes, and obesity causes a lot of disease. So I think these are two different ways at looking at the problem, right? Sometimes we're ignored, and therefore little variants can cause a big problem because let me tell you, it's called the wild type gene, but it's part of the cytochrome P450 system. It's a tiny little difference in an enzyme makes a big difference in how we practice medicine clinically. That's a small thing, but makes a big difference uh, in the patients that were originally ignored in the original studies for the approval of these drugs. And then again, having this small little gene made a lot of people very excited because, genetic medicine is all the rage now. However, I believe important, but not as important as just good clinical medicine and access to care. So I think I just wanted to put those two vignettes out there because, when the questions come, I think going back to my clinical experience, I think is very important when we start thinking about research and how research trials should be run. But anyway, thanks for this opportunity, and I'm looking forward to a robust discussion later.
Thanks, Dr. Melican. That's a really fantastic way to start us out, grounding us in the types of research that might be focused on the outcomes of that research and what we do with it clinically, particularly from the viewpoint of who we include in the trials and what information from the trials we gain and what do we do with it, right, as public health professionals. Dr. Ellis, I believe you are up next and you'll share your own slides, and we're looking forward to it. Thanks so much for joining us.
Yes, thank you so much. And I was a little worried about following the dear doctor, going from clinical to community, but actually you teed me up perfectly there. And particularly when you talk about having an insight into community. So my work here at GW at both the Center for Community Resilience as well as the Institute for Socioeconomic Opportunity is really about listening to that community voice, pairing the science that we have from our various fields, whether that's public health or medicine, but in a way that's meaningful with community, not one rated over the other. And so what we have developed in this work are these equitable community partnership tools that ask the critical questions that I think what the doctor was referring to about the insight. You know, when he gave us the example about the genetic mutation, yes, the genetic mutation is present, but is it the real problem? So we may be going down the wrong path to solve a problem if we're not really looking at some of the external factors, the contextual factors. And a lot of that comes from the community itself. He also talked about the drug trials, the inclusion versus exclusion. Who gets included in these trials ultimately informs who gets excluded from the benefit. And so a lot of the work that we do is really taking into consideration not just what are the benefits that we are trying to achieve, what's the problem that we're trying to achieve, but what is the role of community to be partners, to be co-designers. With our work that we've done here in Washington, D.C., this quote is actually from one of our partners who said, you know, we want to be co-designers. We're not just sitting here on the sidelines waiting for a script to be told what it is that we're going to do. And so when you talk about improving clinical trials or including our knowledge of the application of medical knowledge and research, it does mean that we have to think about who is the community that we're serving, whether that's a patient population, whether that's a neighborhood, whether that's a member organization, a coalition, or all of the above together. What is their shared identity? What are their sources of pride and threats? And ultimately, it's not always a either or, it's typically a both and, meaning that we can serve our medical or clinical research needs while at the same time serving the needs of the community. And so that's, you know, what I think is really important when we talk about avoiding bias. What do we think we know about a community or a patient population versus what we've been told directly from those that we're seeking to work with? One of the most important things when we talk about building these equitable relationships, and that we've learned from our work with a number of different organizations, is this great quote from Reverend Jennifer Bailey. Relationships are built at the speed of trust, and social change happens at the speed of relationships. So what does that mean when we are having an opportunity to serve a community that has been underserved with regard to medical research? What does that really mean when we say we want to come in and we want to help you, but we haven't really identified what you want? We haven't really identified what are the things that are going to most benefit you, and even making that value statement. Well, if we haven't built trust, that's going to be a major impediment to uncovering those things. So when we're working, it's great to have those that are steeped in clinical knowledge, but are you steeped in a community conversation? You may not be the right person to actually be that messenger, to be that communicator. How willing are you to share information with regard to finances? Who's financing this project? Who's getting paid? What are the transparencies in those financial transactions? What are the deliverables that are going to be important for the community? It's not just a written scholarly report, but how does that come back to the community with benefit? We were working with the Milken Institute Faster Cures folks, and they were really looking at how do we work with pharmaceutical companies so that when there are opportunities to test, to do trials in these communities that could best benefit from this, what is the benefit for them beyond just a prescription? What is the opportunity for investment in those communities that is meaningful? It's not an either or, it's back to that intersection of both and. And most importantly, the data. Increasingly, communities are much more savvy with understanding the power of data, the power of their own personal data, and who has access to that. And so do we have a transparency with regards to some of the data that we're collecting? And are we helping to build infrastructure? There's an opportunity to actually build community-based infrastructure for both data collection as well as data analysis. When we talk about these community academic partnerships, this is what is the future, and this is what our community partners are demanding. That's the power of actually, that's the untapped power of actually of partnering with community. So where are you on the spectrum when we talk about community collaborations, partnerships? Are you at the end of ignore, where you just say, hey, this is what we're going to do. We don't really care what the community has to say because we've got XXX dollars for this project and we've got to hit a deadline. We'll sell them on this later. Or are you at the furthest end of the spectrum where you defer to community partners in project design and implementation? It's not an easy place to place yourself, but it's important to think through in the partnership process, how are we going about to actually create a level of equity, transparency, and most importantly, trust? So this tool that we developed in partnership with our community partners is available off of our website. But I wanted to share it with you to ask you to begin to ask probing questions of yourself. The first dimension is shared understanding, understanding what we're going to do and how we're going to go about it. So really, if in the case of testing drugs for a specific ailment or condition, do we understand the context? Just as Dr. Melican spoke to the fact that we can identify a gene that is associated with kidney disease, if you zoom out to community, and we know that the leading causes are really the precursors to kidney disease are heart disease, obesity, and diabetes, what are we doing to address those things in context? What are we doing to create healthier communities for these individuals so they're not getting to the point where that genetic mutation, which is actually a benefit in one context, but a risk in another context, in a context that is unhealthy? So it makes it more likely that that gene will turn on. So do we have a shared understanding of not just the problem that we think we're trying to solve, but that the problems that are actually present in the context of the population that we're working with? The second dimension is around collaborative decision making. Are we working in a way that we can both get our needs met, but what is the decision-making process to support that? What kind of guidelines and processes are we putting in place so that community is being protected, but also community is being advanced? Community power is actually being nurtured in a rightful way. So those are the things that we should consider. Shared understanding, and once we have a shared understanding of what's the problem that we're trying to solve and what's the context around that, how will we go about our decision-making process? Now, I will tell you, this is messy. It's not easy. It's not as easy as just dropping in, helicoptering in, doing your samples and your trials, and then dismiss and go write your paper and present your results. Absolutely not. It's not that easy. But does it have more reward? Absolutely. Will your results be better informed with that kind of contextual analysis that your patient population, that community can provide? Absolutely. Meaningful representation is also important. One of the things that we've learned in the 10 or 15 years that we've been doing this with partners is that you always have to keep talking. It's so easy to go into community and grab a couple figureheads, the usual suspects, those that always stand up. But those that always stand up, are they the ones that are truly representing community voice? Or are they the ones that we've grown comfortable with, that have become pliable, that we know are predictable? That's the easy part. The hard part is to continue to talk and form these relationships. And you know what? When you go beyond the figureheads, that's how you're actually building community trust. Because it's easy to get a figurehead to open up a door for you, but just because they open up that door for you doesn't mean that everyone in that room trusts you. And so making sure that you have these varying perspectives is so important, because just as Dr. Melican said, you can treat one person, one patient population that you've done a deep dive on, but if you've completely ignored the other population, it's meaningless, it's worthless. And so you have to keep those dialogues going. So when you're reflecting upon that, How are you defining your community? What are the groups of people that you hope to benefit most from this project? And are they actually being represented on this team? When we talk about reciprocity, this is making sure that we give as much as we receive. And oftentimes that can be the more challenging part of this, particularly when we talk about, well, what are we giving? One of the things that when we were working with the folks at Faster Cures is to talk about going beyond just cash incentives, but actually paying people for their time, actually involving community members as part of the research team and relying on some of that community wisdom. But also when we talk about reciprocity, we oftentimes will have residents, we will have clinical assistants, we'll have people who are training and getting real skills on our team so they can advance their careers. There are other duties that can be brought into these projects that you can actually hire community members and be adding to their skill sets. So what does reciprocity look like so that it is not just extracting, but there's a mutual benefit? And more importantly, we're reducing risk, but we're also increasing economic opportunities. And I think that's one piece that we've overlooked. It's not just about bias. It's not just about what we think we know about a community, but it's also what are we actually pouring into these communities as we go in to advance the science that we hope long term will benefit them. What are we doing in the short term where we have the opportunities to do so? Where are we doing this in a way that does express reciprocity? And all of this, obviously, is based on respect. You can't do any of this without respect. I am going to respect the wisdom, the insight, the expertise that comes from community voice, the power that is behind that, as well as they can respect my credentials. But my credentials don't make me an expert in their community. My credentials, I could be an MD, but that doesn't make me an expert in this person's health history because I don't know the life story and I don't know the community experience. So all of those layers are so important in being able to understand and be most effective when we are working in community, whether that is in pursuit of a clinical trial, a research trial, a partnership, whatever manner it is, it has to be grounded in respect. So to just recap here, trust, mutual benefit. What are the shared commitments and values that you're establishing? What process of shared decision making are you creating? What type of meaningful representation and opportunities for fulfillment, for job growth, for training are you giving individuals when you're working with them in community? Where are you sharing power? And I do put that in capital letters because it's so important for us to think about where we have to relinquish power, where we lean in, and where sometimes we have to follow. And respecting the expertise and resources that are on the ground, but also be willing to share in the expertise and resources that are endowed in our projects. All of this is rested on a mutual respect for the expertise and training that we have, but also for the expertise and insight that we can gain from these community partners. That's what will help to build these equitable partnerships. These are the principles behind it. And that is, what we think will actually help to create less bias and more understanding and effectiveness in our goals in creating more healthy communities.
Thanks so much, Dr. Ellis, for adding your wisdom to the discussion today. And we'll be sure to include links to Dr. Ellis, to the website, to Dr. Melancon and the website on the work that you've done, and to Dr. Bodrick, of course. And now, last but not least, we'll hear from Dr. Bodrick, and I think you have control over your slides as well. And then we'll build the discussion. So please, of our 167 participants so far, please feel free to put your questions into the Q&A while we're going. And we'll have the discussion after we hear from Dr. Bodrick. Thank you.
Thank you. This is wonderful. A great progression from clinical to community, and I'm going to also be speaking about community engaged research. So thank you all for having me today. Brief introduction. My name is Nia Bodrick. I practice clinically as a pediatrician at Children's National at the ARC in a primary care setting. I serve as medical director for community health and advocacy at Children's, and I also co-direct the Early Childhood Innovation Network, or ESIN, which I'm going to share a little bit about today, and I'm faculty here at GW. So ESIN was a coalition that was founded in 2015 by Lee Beers, was a pediatrician at Children's National, and Matt Beal, a psychiatrist at Georgetown. And we're a local collaborative of health and education providers, partnered with community-based organizations, researchers, and advocates here in Washington, D.C. And what we do is create a space for cross-sector collaboration and co-creation through innovation. We call them innovations or programs. And we really center on those first early years of life from birth to 5. And all of our work uses a 2-generational approach. So we understand that a child does not grow in isolation, and that everything that we do is focused on not just improving the health and well-being of that child, but also their caretakers, as well as the community in which they live. This is our mission. We're very innovative. We use evidence based and evidence informed programs to co-create with our community system transformation, primarily in early child education, early in the earliest years of life for health in children. And we're looking to take ESIN nationally with our model. I like this slide because it provides a little bit of framing about how we do our work at ESIN. We've talked a lot about working in community, and we have our innovations, our programs, our practice that we have. But with all of our work, we have a research and evaluation arm, a practice arm, and then we have a policy and advocacy arm. So you'll see in the top left-hand corner, our founders, our community leaders, Total Family Care Coalition, Parent Watch, and the Health Alliance Network, which are all centered here in Ward 7 and 8 here in DC. Our health partners are here at Children's National, also at Georgetown. We have faculty from GW as well as at the Thrive Center in Georgetown. And then we have our law partners at DC Children's Law Center, and then our advocates at Spaces in Action. And so all of the work that we do, we work center again on early childhood development, taking that 2-generational approach, but we make sure that we have teams that work alongside each other across that spectrum. Dr. Ellis spoke a little bit about academic community partnerships. I like this definition, that an academic community partnership is a collaborative relationship between academic institutions and community organizations to improve health equity. And that is really at the center of the work that we do here at ESIN and at Children's. And that's centered on shared decision-making and co-created solutions. And as Dr. Ellis said, it can get messy to co-create with community, but it's so rewarding, and I think really should be the direction that more researchers take as we start to do more work in partnership with community. And one of the centerpieces of a true, authentic academic community partnership is that we recognize the strengths that we have, right? The expertise that we have sitting in academic institutions or health systems, and also the strengths and expertise that our community partners have, and that those are equal. And we work together to improve health outcomes. So this is really at the heart of what we do here at ESIN. We have our partnerships with Georgetown, GW, Children's, in partnership with all of our community partners. Community engaged research, this definition I pulled from the University of Chicago. It's a collaborative approach that brings researchers and community-based organizations as partners throughout the research process. And I have a very similar spectrum as Dr. Ellis, which looks at the increasing levels of community involvement, communication, trust, and ownership. And in the work that we do, we really try to lean more towards that shared leadership model. So again, starting with community community informed, that's a community as an advisor. So that would typically be something similar to a focus group or maybe a key informant interview. You're coming into the community as a research and you're gathering information, and not necessarily partnering authentically with whomever you're working with or gaining anything from them other than the information that you're getting. Then we have community involvement. So that's when you're collaborating a bit more intentionally with your community. And this can look like a multi-sector working group, of which we have many in DC. And then as you move along that spectrum, you get to shared leadership. Now that's really where you're viewing your community as an equal partnership. This is more aligned with community-based participatory research, which really is a collaborative approach that equitably involves community partners. And then you have, again, the deferred piece or the community-led piece is the last piece where you're actually allowing or providing the opportunity for a community to serve as leaders. I also pulled this slide from the culturally responsive evaluation framework, and I sourced it there, the NORC through the University of Chicago. I think this is really helpful graph to frame community engaged research. You see there's like two different circles that inner ring. It displays the 6 principles of community engaged research throughout each phase of the research process in no particular order. And then in that outer ring, you have the phases of the research process. And so I just wanted to highlight a few of the principles that I think are specifically important to a lot of the work that we do at ESIM, but that could also be very helpful for you as well. The first is avoidance of harm, which is very similar to do no harm, which is a foundation of medical ethics. And what that's looking at is really listening and understanding the community in which you're serving. And this can be a challenge for some clinicians or researchers because we're often used to being the ones that are doing the talking. But I've learned both clinically and working in community that listening first is essential. You'll learn so much more from that than from going in with your set agenda. And this does take time. It takes time. Again, as that quote that Dr. Ellis shared, relationships are built at the speed of trust. That takes time. But it's important for that piece to be done initially from the onset to get a better understanding of the community in which you're serving. So what is this organization's mission, vision, goals? What's important to them? How is that aligned with my goals as a researcher? And then you take that information to help you understand how you can mitigate any potential harm, while also thinking about how that can benefit the community partner as well. Which leads me to transparency and open communication. And that's really, really important. So again, as was mentioned before, who's involved in this study, the purpose of the projects, how resources are shared, who is getting compensated and paid, and everyone should be getting compensated and paid in some way, and how that will be done is really important, leading to accessibility and demonstrated value. So participatory research or research where you have these academic community partnerships similar to what we have at ESIN is that you really want to value, again, the expertise, the skills, the experience of the participants and the researchers equally. And so one of the ways in which we do that is we establish a co-creation process from the onset. And I'll be honest with you, it is something that is really different for some of our community partners because there has just historically been, not just in DC, but nationally, been that sort of power differential where we're coming in as the researchers with our set agenda and we're saying this is how it's going to be. Where would you like to be a part of it? Rather, we're coming together from the very beginning and co-creating both innovations or practices in the community, programs in the community, and also ways in which we can research and evaluate those together. So we talk about what our shared goals are. We talk about the capacity that the partners have for working with you and during that timeline. And, what our capacity and our priorities may differ from our partners' capacity and priorities. And so having that conversation from the beginning and continuing to have that conversation is essential, which leads to the last piece I wanted to highlight, which was capacity bridging and co-learning. So what can we as researchers learn from our community partners and what can they learn from us. This is a shared or co-learning experience. And then even after this whole process is over, we've gone through the whole research, we've published, we've done all the things. How can we continue to partner authentically? How can we provide a space to share, what went well with this? What can be improved? What's next? How can we continue this work? So I wanted to highlight this again. These slides will be shared with you, but it's really a nice way to frame the way in which we can have more equitable research or community partnerships, and to frame the conversations that we have with community partners. I want to end just with a case study from some of the work that we do at Easton. I'm not sure if any of you all are familiar with parent cafes, but they're an evidence-based, trauma-informed, peer-led models where parents and caregivers come together and have guided conversations. And so we frame our conversations around the protective factors. So parental resilience, social connections, knowledge, concrete support, and social emotional competence, using these cards that you see on the right to guide or prompt our conversation. So this is like 2 hours of parents coming together both virtually or in person and having small group, large group conversations about whatever topic that they decide is important. So we may have, like this example is talking about children with special healthcare needs. So we'll get together and talk about how do we use relationships and support as protective factors against the challenges or the adversities that may come with raising a child with special healthcare needs. And these cafes are designed to be led by the parents and caregivers. And so what we did in 2023 is we used a process called photo voice. That's a qualitative research method where the participants are actually we actually gave them cameras, and they went into the community to take pictures of how the protective factors are, how they integrate the protective factors into their life. And so we had this project in March. It ran for about 5 or 6 months, but we specifically asked them to go out and look at how those 5 protective factors that we talked about in parent cafes were integrated into their daily lives. And then we expanded upon that simple process of taking the picture and having the description to train the participants as qualitative interviewers and analysts. And this was a way to really elevate their agency as participant researchers. This was a really, really interesting process. We learned a lot through it, but I wanted to highlight again the things that I talked about in those principles of community engaged research as we went through this process of partnering with our parents as researchers. The first was just avoidance of harm, having that conversation really early on with them and giving them the autonomy to participate as researchers, which most of them did, or not. Transparency and open communication in the way that best worked for them. So we had a Facebook group, we had a WhatsApp group, we had a texting group. We didn't just use traditional means of having Zoom meetings because these were all, for the most part, working parents, or email. We asked them very early on the way in which they wanted to communicate. We were very transparent, again, as was mentioned earlier, about the funding, what we're going to use this information for, and how this could benefit them. And then they were also a part of the evaluation process. And there was a lot of information that we learned from them as we went through this process of training them as researchers. And they were very transparent with us about what was working and then what was not. These are just a few pictures from the event that we had. This was the culmination of the photo voice. And you see probably the best at that picture on the right. That is a protective factor of support. And so there was support. A parent took a picture of how she defined support in her life, and then a description of what we're seeing in the photo. And so it was a very well attended exhibit. As you can see, everyone had a great time. And again, this was a way for us to partner really intentionally with our community, not only with this photo voice exhibit and this process, but the first time that we at Easton had really worked with our participants as researchers. And so I'll just end with this quote from one of our participants. She said, "My role in Photo Voice was one of ownership. I really felt that I was just not thrust into some kind of experiment or another program for caregivers. I really had a sense of ownership in Photo Voice, and it allowed us to be. It gave us autonomy, freedom. It was the most liberating experience I've ever had as it relates to a group project and my role as a host of parent cafes over the past 5 years. It just came full circle. It was, how the kids say, it was a level up." So thank you for your time. You can learn more about the work that we do at eason.org, and I've also shared my email address there.
Thanks so much, Dr. Broderick. This is such a rich discussion so far, and I thought I would start off by checking in with my colleague, Dr. Ndimbale, who has some shaky internet now because he's across the world, but I wanted to check in to see, and feel free, Paul, to chime in whenever you're ready, or if you have, internet wherever you are. But I thought I would start by echoing some of what you all have said. We've mentioned a bunch of ethics principles already today. I didn't do it, you all did it. So, autonomy, equity, trust, avoiding harm, which we call non-maleficence, right? Doing good, which we call beneficence. And among all of you, right? So, we have two physicians, right? And we have all of you are public health experts, public health personnel. So, they're different relationships among individuals, right? Treating an individual, just like Dr. Ellis mentioned, and communities, working within communities, whatever that community looks like. And oftentimes we're talking about trying to avoid bias, and we might be talking about minority populations, and that can look different in different places. And I'd like to raise the idea of group harm to you. And what do you think about in this world of singling out particular communities? And what does that mean in terms of the rest of the world possibly looking at those communities with bias? And Dr. Melancon, you brought this up to me when you were talking about the gene, right? If it is a gene that is expressed in one particular community, maybe other people might think of that community with bias afterwards. And how do we look at that from the standpoint of treating individuals and research trials and choosing what to research as researchers? And then how do we reflect that when we're working with individuals and groups in our society, wherever that may be? And I know all of you have worked in different places. What does that look like to you?
No, Melissa, it's a great question. And in my answer, I have to ask a question to Dr. Bodrick. What does it mean to level up? Because, I think I'm going to use that in my answer. So I want to make sure that what I think of level up is and what you think is the same thing. So what does that mean?
Yeah, to me, it means to elevate.
Okay. All right. Good. All right. Good.
Yeah.
But so in my answer, Melissa, here is the problem. I believe that this focus on this genetic issue was like, it was a way of saying they are different, right? And it was also a way to say, the medical community is not to blame because, wow, these people that have this genetic issue that we never knew is why they have this problem that we are seeing, right? Rather than, I believe, the fact, which is, it's a shame that in the richest country in the history of the world, that very, very simple issues are not being dealt with. And I'll give you an example. When you look at people from the African diaspora in Europe, particularly in France, you do not see the same levels of cardiovascular, vascular, and kidney disease that you see of people in the African diaspora in America, right? Now, it's funny because I've had this debate with colleagues, and they want to make the argument that the African diaspora is different in France than in America, right? In other words, African Americans are just somehow more diseased. But I'm not saying it's not, there's no facts to that. But what I'm saying is access to care matters, right? And that's such a approachable thing, right? But like I said, they are so interested in, it's almost like fetishizing this genetic thing, right? Let's go and find this secret little being that causes problems in African Americans. Now, I'm not even going to get into the pharmaceutical side of this because there are pharmaceuticals that will follow. I guarantee you, it's already happening. But the point is that I believe it is shared harm, right? Because you're ignoring what really I believe is the main issue, which is we should be concentrating on the simple stuff. And the simple stuff is giving better access and treating things. I mean, this stuff is relatively cheap to fix. Throughout my career, I've seen people go from no proteinuria to a little bit of proteinuria to a lot of proteinuria to the creatinine going up. I mean, it's not rocket science. And I think a lot of these issues, and you heard this from your panelists, is starting where the rubber meets the road. One of the things, which is why I asked Dr. Broderick that question, I'm going to tell you something that's simple. And it's not so much, why do communities like to hear from people of the same ethnic group oftentimes, right? They'll say Black doctors do better with Black patients, which I don't think it's a Black to Black thing. I think it is an understanding, or at least an attempt at understanding. I don't understand a lot of this slang any more than a white guy would. However, I know that it's important to understand colloquialisms, right? So if I want to well communicate with the people I'm talking to, I'm going to take the time to try to understand what they're saying. Give you a quick example. Young Black men have one of the biggest problems with undiagnosed or untreated high blood pressure, right? Almost all of the high blood pressure medications can cause impotence, right? So if you're communicating with young Black men about the medication that might cause impotence, then you would be well versed to understand that might be a problem, right? So you want to communicate with them very well, understand if a beta blocker doesn't work, then we need to go to an ACE inhibitor, we need to go to whatever works for them works. But you better be having a good conversation about the side effects and understand how they're going to express that to you in whatever colloquialisms they may utilize. So that is part of what I'm talking about, and what you heard your panelists mention as far as communicating with the community. I love the idea of going into the study with the community rather than going to the community and say, hey, yo, I got this study and this is what we need you to do. So I think that's the answer to your question, that shared harm is these like blind spots that we go into the community with. And since it's not a two-way street, since you're talking at them rather than having a conversation, the blind spots remain. Because, you may go in with the thought, which is okay. I mean, we go in naive and then the blind spots go away as the community informs us. But if we go in with an agenda and we have these blind spots that never go down, then we come out with a misunderstanding. That's where so much of the non-adherence or non-compliance comes from. I believe a lot of it is misunderstanding. I hope I answered your question, but
I want to thank you so much for that, because I want to actually highlight something that I've brought up on one of these other webinars about the potential harm of othering people with experiences that are actually pretty widespread throughout our country, and that's adverse childhood experiences. In the last 10 years, I mean, that's what I have grounded my work in, is adverse childhood experiences. And one of the things that we understand is that those are actually precursors to obesity, to mental illness, to substance use, to diabetes, because it creates this overactivation of the HPA axis. So what we saw, particularly in the last 10 years, has been this medicalization of the science of ACEs to reduce individuals down to a score. Now, we do know that the higher your ACEs score, the higher your risk level is for these chronic diseases and ill outcomes, socio and economic outcomes. But they are predictive, but they are not indicative. So it's not exactly a science in the sense of you have 8 ACEs, you are now going to be a drug abuser, this, that, and the other. Um, but what the science has been shuttled to is to say, let's screen all of these children and their parents for ACEs and then move them into this category. Let's begin to look for biomarkers of ACEs so that we can begin to perhaps think about treatments rather than ACEs are preventable. If we get in early enough, we can treat both the child and the family as a dyad, but also look at the community context that oftentimes contributes to this accumulated stress over the lifetime. But no, we want to categorize and other these people. And for me, when I see that happen, we've seen what happens with data points about our children, and one in particular that should be a good predictor is how we use reading scores, third grade, sixth grade reading scores. State legislators look at that and say, oh, so that's how many juvenile justice cells we should have in 10 years because we've got kids that are falling behind. So if you're using that sort of logic from the data that we're pulling out of our systems, who's to say that such things as ACEs score won't also become these determinants that then shuttle our kids in different ways? That's how we other people. And I think that, that's the science that's happening in plain sight, that we're not necessarily having the conversation on the front end, as opposed to waiting until the science has been released and is being implemented in all these harmful ways.
Thanks so much, Dr. Ellis. Dr. Bodrick, I want to pull you in here if you'd like to jump in and level up, right? So
No, I totally agree with both Dr. Ellis and Dr. Melicon, and that's, you know, I agree with the emphasis on the science of ACEs. Some encouraging news is that there really has been a shift within the field of pediatrics to looking at positive childhood experiences, or PCEs, which are some of the things that we talked about with the parent cafe model. And as Dr. Ellis mentioned, that ACEs are preventable. So we're putting a lot of our effort and work into figuring out ways, even prenatally, that we can support parents and their communities and children to prevent ACEs, and ways in which we can pour into the soil and provide a space for knowledge, and then also supporting parents. And this is both at the community level and at the systems level. And so we don't spend a lot of time in the work that we do in othering children or putting them into boxes based off of their background or their problem list or anything like that. And I think that really is the next phase. Everyone's not there yet, but we're getting there.
thanks so much, Dr. Bodrick. I want to acknowledge our colleague Shaniqua Collier from the School of Medicine and Health Sciences, who has posted a couple of fantastic Q&As. I'm not sure, Dr. Collier, if we can allow you to speak so we can hear you, but we can all see your Q&A about strategies that have worked for meaningful community engagement, especially when funding is also limited, which we're all quite aware of now, and devoted to the science. What are some ways you've seen investigators passionate about this, but with little to no money for it, engage communities in meaningful ways? Also, could you also please comment on strategies for maximizing bidirectional learning when a community may not know what APO1 is, for example? And this is probably the last question. I want to get you all in here, but we will preserve all of the Q&As, and everybody will send them to you so that you can respond. But I'll give you this one now.
I'll just dive in really quickly. One of the techniques that we use in community are typically we have this pair of aces tree. I think Nia was alluding to that, but it's really a way that interactively we're learning about the social determinants and the political determinants that impact the environment that the community's living in, and at the same time they're learning the science of social determinants and political determinants. And it's really helpful when we're preparing them to be advocates. So we also do a whole training on advocacy so that they can actually use the science and our findings to go advocate for themselves. The other things that we do are community engaged research methods such as group model building. And so we actually train up our community partners to be leaders in that process. So that's a hard skill that they're learning that they can apply, whether that's in other community environments or, for job development later. Those are real research skills that oftentimes we are bringing them onto the team and passing that on.
Yeah, I agree. We do some similar methods with always making sure we're whatever our budget is, as small as it is, building in our community partners into the budget, but also going back to those early conversations that we're having with our partners, seeing what their needs are, their non-financial needs are. So we also offer trainings. We've also provided technical assistance with their current work. We do quite a bit of work in workforce development and parent leadership. And then as we continue to seek funding together, looking at opportunities to do some capacity building just for the organizations themselves, like with their internal organization, and then also in partnership with us. So we have found some creative ways in which we can partner, really just by asking questions like, what is the support that you need for your organization outside of this research project? Are there ways that we can help in that way? And then as we're doing this work together, we have a limited budget, but what are some other ways in which we can support you?
Yeah, I would just echo all of those things because first of all, Melissa, Shaniqua was the on the inaugural committee that you're on right now.
Yep.
So it's good to hear from Dr. Collier. But I will just say that, like Dr. Ellis and Roderick mentioned, these community partners that we work with, we actually get them to help us educate the community. So they come in, work with our team, and basically give us pointers before we even interact with the community. And I think this is even more important in the environment that we're in now. Our community partners are helping us fundraise. So since the federal funding is becoming more and more problematic, we have to we have to rely more on private philanthropists. And private philanthropists love hearing from people that are in the community. So those community partners, now I'm pulling them in to say, hey, I want you to be at this meeting because it's such an important part of getting the money in. So I think both ways your community partners become very important.
Thank you all. This has been such a rich hour. It's quite amazing that we've gotten it all on this rich hour. Thank you so much. You can see in the Q&A the appreciation from our community, the big community. I want to update you all very quickly on our next programs here. You'll be able to see in the slides a discussion a month from now on why study religion and spirituality and bioethics. And following that, we have actually before that, we have our big forum hybrid meeting in person and online on March 3rd about the idea of the ethics of public health information. What is actually involved in expressing all of this information and learning from our environments through communication. But I want to thank each one of you very much for joining us today. I hope that we can continue the dialogue among this group and among all of our panelists. We have several other, we have colleagues who attended today, many, many students of all stripes and varieties. So we've gotten a really good, you have a community to help and work with you and to teach. Thank you very much. And thanks everyone for joining us today. Thanks, Dr. Ndambale over there, wherever you are right now. And we'll see you again here in a month. Thanks all.